All right, we got Panopto going, and that's, hey guys, one of the things I wanted to remind everybody of, okay, is that we're recording these lectures every day using Panopto, okay, and on your Canvas site, if you scroll down the menu bar on the left, you'll come across Panopto. It'll say that word Panopto. If you click on that, you can see all the audio recordings, okay? Panopto is pretty cool. It will provide you, I think, with a complete transcript of the entire lecture, okay? So again, if you're an English language learner and you want to translate the entire script into whatever language it is that you want, it can really help, okay? You can upload the transcript and copy paste the transcript into an AI platform and have it, so there's a lot of options there, okay? So don't be afraid to use that. All right, so today we have to finish up RAS agents. I forgot about that. I'm getting too excited. We're getting into calcium channel blockers yet. But before we do, I'm going to take this down and put the RAS agents back up. We're going to do a little bit of active recall. Yes, everybody's favorite thing to do, right? Remember, active recall or self-testing is your #1 evidence-based learning strategies, okay? You have to trust me when I tell you this. I am not going to ask you to read your notes as part of the exam, okay? I'm not going to ask you to recopy your notes as the exam, right? I'm going to ask you to remember facts and information. I'm going to ask you to describe things, or explain things, and apply things. So is Dr. Naeem, okay? So practice the way you're going to be tested, okay? First things first, so you can pull out a blank sheet of paper, you can open up a blank page on your tablet or laptop. No cheating here, okay? And a couple of things I want you to do. I'm going to ask you to do a couple of things. The first thing I want you to do, okay, and this will be easier on a tablet than it is a laptop if you can draw, is I want you to, in whatever way you can, recreate the RAS pathway. Oh, yeah. All right, with all the substrates and all the enzymes, okay? Go as far down as you can go, all right? And as you're doing that, I'm going to get up the RAS lecture, okay? I want the RAS pathway, okay? You only need to do the one side, okay? Remember the left side, okay? Give me the renin-angiotensin-aldosterone pathway, okay? Okay. Okay. It's the first substance, right? First enzyme, second substance, second enzyme, and third substance. And if you finish that up, if you've got it, see if you can slide the drugs in there. Where your drug target's at. Okay? If you want to. If you're still working on the RAS cascade, that's okay. Give you 15 more seconds just to get one or the other done. Go. 5, 4, 2, 0, stop. Okay, good. Wherever you're at, stop. It's okay, okay? And again, part of this is just practice and showing you what you need to do. So let's go here. Let me get this on real quick. Okay, let's go here. Okay, remember, learning objective number 1. Describe the different steps of the RAS pathway. I'm going to test you on that. It's a learning objective. Okay, so make sure you can do it. You don't have to guess. It's right there. Okay. Now, this is your. Now I'm going to do a self-check. This is your self-check part, right? When you go and do a self-check, you're checking your answer to see if it's correct first, right? What did you get right? What did you get wrong? Okay, it's right over here. What did you miss? Okay, if you got something incorrect, okay, this is your time to think about it a little bit, right? If you don't understand something, you may go back to the Panopto video and watch that particular slide again to make sure you got it. Or if you've got an AI platform like ChatGPT, okay, you can always quickly type in, I don't understand how angiotensin II causes vasoconstriction, okay? And it'll tell you. It's pretty good at that. I think ChatGPT 5 right now is really great at explaining science concepts to you, testing you on it, right? Explaining to you at an easy level and then an advanced level. So if you're using that, don't hesitate to use it. Where I think you can get into trouble is depending on it to explain to you clinical reasoning. I don't know where it's quite at there yet, okay? Will it get there? Yeah, but we're not quite there yet, all right? But what it will do is it can generate patient cases for you, practice cases, right? So you can practice figuring out what kind of drug you need to give your patient with hypertension, all right? And then if you're not sure, talk to one another or go see Dr. Naeem, okay? Everybody got this? All right, one more. This one's a little bit trickier, right? Because if it's not hard, you're not doing it right? If you're not stressing yourself a little bit in your brain, you're not learning as well as you can. What are the 3 subclasses of ACE inhibitors? Okay, you remember those we talked about? And why do we classify them that way? What is it about their chemical structure? Right? We said there's something special about their chemical structure that, causes them to be in one category or another. Okay? What do you think the 3 subclasses are of ACE inhibitors? They're chemical classes. And remember, it's okay to do this by yourself and then check with your neighbor, but try to do it yourself. Five, 3, 2, 1. All right. What's one subclassification of ACE inhibitors? Dicarboxylic acid, right? And because it contains a carboxylic acid group, which is its what? Zinc binding group, right? What's another subclass? Sulfhydryl. Does anybody remember the only one example there? Captopril. And why don't we use captopril anymore?
The dosage.
Yeah, because it has to be dosed multiple times a day, right? Okay? All right. What's the third class? Phosphorus. Okay, great. Like phosphinipril, right? Phosphorus. Okay? Okay, very good, right? And all you got to do is look for that zinc binding group, right? All right, now, one more question. What side effect, okay, what side effect do all of your RAS agents have in common and that you need to keep an eye out for? Hyperkalemia, right? Okay, very good. Okay, which of your RAS agents have the cough side effect? And if your patient gets the cough and they can't stay on it, what are you going to switch them to? You guys are geniuses. Great. Okay, good. All right. Very good. All right. Don't ignore this either. Okay? Because I will ask you about this. Hemodynamics here. How do ACE inhibitors lower blood pressure through this hemodynamic mechanisms? Okay? and you know what, remember, you know one group, right? You know, like the ACEs, the ACE inhibitors, you know all of them, because they're all the same. The slide is identical for each group of your RAS agents, yes?
Quick question.
Yep.
I just want to clarify if peripheral vascular resistance is the same as total.
Yep. So let me explain this to you, okay? Total peripheral resistance here. You'll see that sometimes you see these words being interchanged. I want everybody to pay attention. This is super important. Total peripheral resistance is what I refer to as an umbrella term, okay? So it's a big term that describes a lot of little things, okay? Total peripheral resistance is the total amount of resistance to blood flow in the body. And there are a lot of different things that can cause resistance to blood flow, okay? I've got 3 major ones that I mentioned in that video, okay? The first one is systemic vascular resistance. What's another name for SVR? Afterload, okay? They're essentially identical, okay? So again, what is SVR and afterload? It's the amount of constriction of arteries or dilation. So if your arteries are really, really constricted, SVR is going to be high, right? Because they're going to be very narrow and it's going to be hard to blow or to allow blood to be pushed through those, right? It's sort of like, right, if you had to blow through air through a tiny straw, like this, or if you make a tiny hole like this and try to blow through it, it's hard, right? Okay? But if you open it up, super easy, okay? SVR, high. SVR, low. Got it? It's that simple, okay? 2 other things that can increase vascular resistance or systemic vascular resistance. Elasticity of your blood vessels, right? We know in young, healthy people like yourselves, your arteries are very supple. They're like a rubber band or a balloon, right? And so, again, as pressure increases, they can expand a little bit, right, to accommodate for that, right? But as you get older, like me, right, and you've had way too many Five Guys cheeseburgers, right, your arteries can get more rigid and they can lose that elasticity. And that creates resistance to blood flow. Okay, everybody got that? So that's another thing. Blood viscosity, how thick your blood is, okay? So again, this is not something that normally happens, but if you're taking a drug like erythropoietin, okay, this sometimes can happen to endurance athletes that are doping. They're taking erythropoietin to increase their cardiovascular performance, right? Their blood can get thick because of the increase in red blood cell production. And that can increase the resistance to blood flow, okay? So those are 3 major, it's not all of them, but there were 3 big contributors to total peripheral resistance. Everybody got that? All right? So a lot of times what we focus on with our drugs is this right here. Anything that will relax your blood vessels, your arteries, okay, will reduce SVR. And most of the drugs we're going to talk about yesterday, today, and tomorrow all reduce systemic vascular resistance. Okay? ACE inhibitors do, ARBs do, direct renin inhibitors do. Today we're going to talk about calcium channel blockers. Okay? Some of your calcium channel blockers are really, really good at this. Not all of them, but some of them are. And I'll tell you which ones are and which ones aren't. We're going to talk about hydrochlorothiazide, which is a diuretic, okay? But guess what? Its main blood pressure lowering effect is, I'll spoil it, spoiler alert coming, it reduces SVR, okay? Even though it's classified as a diuretic and it does have diuretic effects, it also relaxes blood vessels, okay? Everybody understand that? So that's an important mechanism to know, all right? Over here, stroke volume. This is one where people get really confused about. This is a hard one to understand, all right? It took me a while to get it, okay? Stroke volume, by definition, is the amount of blood ejected from the left ventricle every time it contracts, okay? It's about 70 to 80 milliliters of blood, okay? That's stroke volume, okay? As the heart contracts or strokes, right, as it contracts, it ejects blood into the aorta, about 70 to 80 milliliters. It can vary depending on the circumstances, okay? Now, again, things that can increase the amount of blood ejected from the left ventricle every time it contracts. There's a couple of things. I mentioned it in the video. First of all, sympathetic nervous system, when it's activated, right? Okay, looks like that Maui's not here, so Kingsley, man, you're on grizzly duty today, okay?
That's okay.
I know, that's why I picked you, because I knew you were the right man for the job, right? So if that grizzly bear comes waltzing in the back of the room, right? What happens to our fight or flight response? Right? I mean, we are all terrified. Our sympathetic nervous system, right? We're running for the door. But what happens to our heart rate under that circumstance? Right, it goes up, right? This is what's happening right before your PT exam when your heart's racing, right? Okay? The other thing that's happening is that those catecholamines that are causing your heart to beat really fast, they're also causing your heart to pump more forcefully. They're increasing stroke volume, okay? And that, both of those together increase cardiac output so that you can fight the grizzly bear, thanks Kingsley, all right? Or you can flee out the door behind me, okay? All right? You got it? Now, the other thing that will change stroke volume, that one's easy to understand, I think, relatively easy, right? Okay? Is the amount of blood in the left ventricle, okay? Preload, all right? Preload is a term that describes the amount of blood in the left ventricle before it contracts. It's loaded up, preload. It's the load on the heart before it contracts, right? All right? And it turns out that the heart can make adjustments to how forcefully it contracts based on how much blood is in the left ventricle. Okay? The more blood in the left ventricle, the more forcefully it will contract because it has to get that blood out of there, right? That's the Frank Starling mechanism. Okay? And there's an upper limit to that, right? Okay? It's sort of like if you pretend your left ventricle is a balloon, okay? And you blow a lot of air into that balloon and it gets really big, and you let go of the end. Is that air going to come out pretty fast? Is that balloon going to collapse and push that air out of there forcefully and quickly, right? Versus if you only blow a little bit of air into that balloon and just blow it up a little bit, the air's still going to come out, but it's going to be less forceful and less quick, right? Same thing with preload. Preload is like air in the balloon. The more air you have in the balloon, when you let that balloon go, the more forcefully the air comes out and quickly the air comes out, right? With the left ventricle, same thing's true. The more blood in the ventricle, the more those muscle walls of the heart get stretched, and the more forcefully they contract to eject blood into the aorta. Everybody understand that? That's preload. So again, if you decrease preload, you decrease stroke volume. If you increase preload, or the amount of air in the balloon, you'll increase stroke volume. Okay? Everybody got that? Now, what determines how much air is in the balloon? Or how much blood is in the ventricle? Okay? Well, one of the major things is blood volume, right? The more blood you have in the circulatory system, the more blood you're going to have in the left ventricle, right? That's pretty easy to understand, right? And that's what we're talking about here. Okay? The other one is venous return, if you remember from that lecture. Okay? Venous return is the amount of blood coming back to the heart through the venous system, right? Because remember, your heart pumps blood into the arterial circulation, right? Goes through arteries and arterioles and capillaries and then into the venous system. And it comes back to the heart and the heart recirculates it, right? Okay? It turns out that your veins, your venous system, is actually a place where blood can be stored and mobilized if needed. Okay? Right now, you guys are sitting there, it's post-lunch, right? So you're in food coma, you're desperately trying to stay awake. I get it. All right, I won't pick on you, all right? And your blood is in your veins. There's a lot of blood in your venous system right now sitting there. Have you ever stood up like when you're sitting in class really fast and you feel like you're dizzy and you're gonna pass out? That's because all your blood's in your venous system. It's pulled there and it's not going to your brain. But you don't pass out, right? Because your body adjusts, and what happens is your veins constrict and start pushing all that blood back towards your heart. And then it goes to your brain and you're okay. When that grizzly bear walks into the back of the classroom and we're all sitting here, and our fight or flight response gets activated, okay? Lots of stuff's gonna be happening in your body. Your heart rate's gonna go up. Your stroke volume is gonna go up, and that's gonna increase cardiac output, okay? You're gonna get venoconstriction. All the big veins, especially the bottom of your body, are gonna start to constrict, forcing that reservoir of blood back up towards the heart. That's venous return. That's an increase in venous return. And as all that blood starts coming back to the heart's gonna beat even more forcefully to keep it moving so it doesn't get overwhelmed, okay? So venous return, all right, is a determinant of stroke volume. When the sympathetic nervous system is activated, it can increase stroke volume. So there's a couple of different ways your body can adjust stroke volume, okay? ACE inhibitors, ARBs, and DRIs reduce stroke volume by reducing preload and by reducing afterload, making it easier for the heart to push blood through the circulation, okay? All right, good. Now let's get to the end here, all right? This is where we left off. We said that your RAS agents, especially your ACEs and ARBs, are renal protective, okay? Why? Okay. And I'm going to explain to you why. And it has to do with the special effects that angiotensin II has on the kidneys when it's being produced, okay? And before we get into that, let's talk a little bit about how kidneys function here. So up here, we have a cartoon picture of the first part of the nephron, all right, which is the Bowman's capsule, right, containing the glomerulus. Now, I drew the glomerulus as kind of like a big red balloon, not like a capillary bed, to give you an idea, just because it was easier. We have one blood vessel coming in, the afferent arteriole, that brings blood into the glomerulus, and then we have efferent arteriole that takes blood away from the nephron, okay? And again, when the amount of blood coming in is balanced with the amount of blood coming out, you get steady hydrostatic pressure in the glomerulus, which will cause filtration of water, electrolytes, and very small molecules. That's glomerular filtration rate, okay? Now, what if we have a situation where you have a dangerous spike in blood pressure, okay? Let's say your blood pressure is elevated really high. I'm talking like systolics 190, 200, right? Super high, dangerous blood pressures. What happens is, if blood pressure in your entire body is high, the pressure in the afferent arterioles of your nephron is going to be high, right? There's going to be a lot of blood coming in and very high pressure into the glomerulus, increasing hydrostatic pressure and blowing up that balloon. And what did we say happens to balloons yesterday when there's too much air in them? They pop, right? Guess what can happen? It can rupture, okay? And once it ruptures, what? Can it repair itself? Nope, that nephron is now dead, okay? So if you think about it, is there a way that we could potentially relieve some of this pressure in the glomerulus using these two tubes here? We got way too much coming in here. We can't do anything about that, but what could we do with this tube? Yeah, if we dilate it or increase its size, we can relieve some of the pressure there, okay? So let's take a look at just that. How do ACE inhibitors and ARBs do exactly that? It turns out, okay, that the efferent arteriole here is very sensitive to angiotensin II. When angiotensin II is present, this efferent arteriole constricts down, okay, and increases glomerular hydrostatic pressure. Okay? Now this occurs in all of us, especially when your blood pressure is low, right? Your kidneys don't like to operate at low blood pressure. So if your blood pressure falls, the RAS system gets activated, angiotensin II gets produced, that constricts the efferent arteriole and keeps your glomerular hydrostatic pressure at a relatively normal rate so that your kidneys are still filtering blood and doing everything it needs to do. But if that gets out of control, okay, it can cause damage to that glomerulus. And that's what we're really talking about here, okay? So if we give an let's say this person here, let's say we have the same situation up here. We have a person with elevated blood pressure, really high blood pressure, all right? Or maybe their blood pressure is really high all the time. And we give them an ACE inhibitor. It's going to lower SVR, it's going to lower stroke volume by reducing preload and afterload, okay? We know it's going to do that, but it also has a special effect on the kidney. And what it does here is right up here. Circle that, star it. It causes the efferent arteriole to dilate. So even if the pressure is really high coming into the glomerulus, ACE inhibitors and ARBs allow that output blood vessel, all right, to dilate. And that helps to bring pressure in the glomerulus down and prevents it from popping or rupture. Okay? This is why we say ACEs and ARBs are renal protective. Because when you're taking them, your efferent arteriole is pretty dilated. Okay? And again, even if your pressure is a little bit high, you don't have to worry about your glomerulus popping because your output out of the glomerulus is pretty high because that blood vessel is nice and dilated, right? Okay. Another example, if you're not understanding that, okay? Kingsley, go ahead with the question first.
I'm looking at the afferent arterioles,
Yeah.
also arteries.
Yeah.
Is this effect going to be only on the efferent?
Yes, it will dilate the afferent arteriole a little bit. The efferent arteriole is very, very sensitive to angiotensin II levels. Okay? When angiotensin II is present and acting on that blood vessel, you tend to get way more constriction of the efferent arteriole than the afferent arteriole. Okay? And when ACE inhibitors or ARBs are on board, okay, you get dilation of both of those arterioles, but the efferent arteriole is going to dilate really, really well. Okay? That blood vessel is just way more sensitive to angiotensin II. Okay? Yes, sir.
So if you have a patient with CKD.
Yep.
Is like this preferred for like CKD patients?
So again, it could be a drug that you could use again in a CKD patient. I don't remember who's teaching renal, but you're going to learn all about that in renal. But yeah, definitely you're going to hear ACEs and ARBs again. They're going to talk about how they're good for the kidneys, and this is why. Okay. So again, if we pretend here, okay, that this room here is the inside of your glomerulus. We're all inside the glomerulus. And let's say there are 5,000 people outside that want to get into this room. And we've got one door over here, right, for people to get out. And we let all 5,000 people in through that door over there. What's going to happen to this auditorium? It's packed. It's going to get way too full. You can't move, right? Even if I open up this door and allow people to leave, the amount of people coming in is going to overwhelm the amount of people going out, right? But if I give an ACE inhibitor, what I'm going to do is I'm going to blow a hole through this wall, right? Open up this space so more people can come out. And so now, the amount of people coming in can be balanced by the amount of people going out. And we're all going to be comfortable here. We're not going to rupture. We're not going to blow up. So ACE inhibitors and ARBs, okay, is like opening up this door over here, blowing out this wall, so that lots of people can leave as lots of people come in. That kind of balances things out. Everybody understand that? Okay? Again, this particular diagram shows something that I just talked about. When regardless of, we're not talking about a situation here where blood pressure is high, but now down here we're talking about a situation where blood pressure is dangerously low. Okay? The RAS system is so important in protecting the kidneys in those circumstances. Okay? Because when blood pressure is really low, is the RAS system activated or deactivated? It's activated, right? And angiotensin 2 will be produced as a result of that, causing constriction of this blood vessel here, the efferent arteriole. Okay? And that will help to maintain normal glomerular hydrostatic pressure, even if you don't have enough blood coming in here. Okay? So again, the RAS system can help protect kidneys under low blood pressure situations, but under high circumstances where the blood pressure is dangerously high, if you want to protect the kidneys, you can give an ACE inhibitor or ARB and prevent the rupturing of the glomerulus, right? You don't want it to collapse either, right? You don't want it to collapse. So again, it's a dynamic thing. The only thing you understand right now is that ACE inhibitors and ARBs are renal protective, and they can prevent nephrons from rupturing or dying under high blood pressure circumstances. That's good. Everybody should understand that at this point. Even if you don't understand how that kind of works using this diagram, at least understand that. ACEs and ARBs are renal protective, especially under circumstances where someone has very high blood pressure or prolonged high blood pressure that's not controlled, okay? Because it prevents the rupturing of the glomeruli in the nephrons and preserves kidney function, okay? If you know that, I'm happy, because as clinicians, that's what you need to know. If you don't remember the afferent efferent arterial thing, okay, might you miss a question on the exam? Maybe.
Can you repeat it again?
Yeah, absolutely. So what you want to know, right? The one thing you want to know is that ACEs and ARBs are renal protective, okay? And they do that by preventing damage to glomeruli in nephrons when blood pressure is really high over a long period of time, okay? That's important for you to know as a clinician. No doctor is ever going to come up to you and ask you about the afferent or efferent arteriole, okay? So don't worry about that.
This would also apply to ARBs as well.
Pardon me? ARBs, ACEs and ARBs, yeah.
ACEs and ARBs.
ACEs and ARBs, okay?
Okay.
All right? Everybody got that? And you'll learn more about that in the renal module, okay? And how that works in kidney disease and stuff like that. But again, somebody with hypertension, right? Prolonged hypertension without treatment can damage your kidneys. You guys know that, right? If I have high blood pressure and I don't know it, and I've been walking around with it for 10 years, I probably have some kidney damage, right? But if you start somebody on an ACE inhibitor or ARB, okay, not only can you lower the blood pressure, but you get a little bit of an extra benefit in terms of kidney protection that you don't get with calcium channel blockers, that you don't get with hydrochlorothiazide. Got it? Okay? And if you have somebody with high blood pressure and they've got a little bit of kidney disease, that could be a reason why you might start an ACE or an ARB instead of some of these other drugs. Make sense? Okay? You can kill two birds with one stone. That's a good thing, right? If you understand that phrase. All right. This particular slide deals with something called renal artery stenosis, okay, and ACE inhibitor usage. I think we're going to skip that, okay? I don't think we really need to know that, all right? Dr. Naeem may mention renal artery stenosis and how it's not good to use ACE inhibitors under that circumstance because of what's going on, okay? I won't test you on that, okay? But for those of you that are interested, a brief explanation. You don't have to write this down, just pay attention because I'm not going to test you on it. renal artery stenosis, right, is a blockage, and it's on Panopto too, you'll be able to listen to this again if you want to, is a blockage of the renal artery. And if the renal artery is that major artery that feeds each one of the kidneys, right? If we block that artery by 75% with that, like an atherosclerotic lesion of some sort, right? What's going to happen to blood flow to the kidney? Is it going to go up or down? If you block the artery that takes blood into the kidney, right? Is blood flow to the kidney going to go up, increase, or decrease? It's going to decrease, right? Because there's a blockage there, right? What's that going to do to blood pressure in the kidney then? Just in the kidney. If you have less blood going into the kidney, right? If blood flow is being blocked. So it's like if you have lousy water pressure, right? Let's say one of your pipes in your house is blocked going to your shower. What happens to the water coming out of your shower head? It just kind of dribbles out, right? It's terrible, isn't it? Right? That's the same thing that's happening in your kidney. Blood pressure in your kidney is going to be low in that circumstance. So if you have a renal artery stenosis that blocks blood flow to the kidney, let's say to your right kidney or left kidney, okay, or both, that's going to reduce pressure in the kidney. Now, what's the kidney going to do in response to that? It's going to activate something that we just learned about. It's going to activate the RAS system, okay? Now, just remember, blood pressure is normal in the whole body, but there's just this little blockage here, right? In the kidney. So the kidney's all panicked. I'm not getting enough blood, so I'm going to activate the RAS system to get more blood. And I'm going to do that by increasing blood pressure everywhere. Right? Okay? And then that poor person, right, is going to go to the doctor and they're getting their blood pressure measured. And you're like, holy smokes, your blood pressure is 190 over 115 or 120, okay, or whatever. We're going to start you on an ACE inhibitor. Oh boy, that's bad, right? Because blood flow to the kidney is still low. And if you add an ACE inhibitor, what's going to happen to the efferent arteriole? It's going to dilate. What's going to happen to the nephrons? Collapse. Okay? So again, Dr. Naeem, and again, if you don't get that, listen to that Panopto description again. Okay? I'm not going to test you on that, but I think it's important just to kind of explain it. If you get it, great. If you don't, just remember when Dr. Naeem, if she talks about renal artery stenosis and ACE inhibitor use, you got to be really, really careful. Okay? All right? Yeah.
So when people have that condition and they don't know it, sometimes they give the S inhibitor and provoke more damage to the
Yeah, so that's why we're measuring kidney function a lot of times, right? You know, because again, if you notice a reduction at GFR, right, then you know that there's a problem there. Right?
Because they the lab is take too much time and they want to prevent whatever the blood pressure go down. Right?
Yeah, and so for most people it's not a problem, but again, like I said, Dr. Naeem will talk all about this, right? There are ways to determine whether somebody's got renal artery stenosis and whether that ACE inhibitor is hurting your kidney or actually helping it. Okay, under normal circumstances where the blood flow is good everywhere and you have high blood pressure, ACE inhibitors are great. If you got a blockage in the renal artery, a stenosis or blockage, okay, that could be really bad. All right? Great question. You guys are great. You guys are doing a great job here. I'm really impressed. All right, good. All right, so let's leave this behind here. Okay? Let's move on to calcium channel blockers. Jess, you got us for break at 2:30, right? Okay, and don't let me at 3:30. Okay, don't let me go on any further. All right, save us. All right. So next group of drugs, these are also first-line agents, are your calcium channel blockers. Okay, learning objectives. We're going to do some structure-activity relationships. There's going to be some med chem here. Okay, I'm going to tell you exactly what you need to know. All right, all right, and describe how both the dihydropyridine and non-dihydropyridine calcium channel blockers, okay, reduce blood pressure. I also want to add another one on here that's similar, okay? I want you to be able to compare and contrast the effects of the dihydropyridines and they're non-diegetic. This is kind of implied here, but they have some similar effects, and they have some different effects we're going to talk about, okay? And I'll make sure I point those out. I've got a couple of tables in here that will really help you to see what the differences are, okay? So very, very quickly, Dr. Chatterjee went over this 2 years ago in biochem, okay? Did I teach you guys, I think I taught you guys simple transduction, right? So again, calcium is critical for muscle contraction. Hopefully everybody remembers that, right? Whether we're talking about skeletal muscle, whether we're talking about cardiac muscle in your heart, or whether we're talking about smooth muscle in your blood vessels or in your GI tract or your bronchial pathways, calcium is necessary for muscle contraction, okay? Now, imagine we're talking about your arteries, right? And your arteries, for some reason that we don't understand, are really constricted all throughout your body. They're just contracting and constricting, right? What's one way we could relax them a little bit? By removing some of the calcium that they can use for contraction, okay? And this is the IP3 pathway. Okay? This is a very, very important signaling pathway in vascular smooth muscle, that muscle that's in your arteries and even in your veins, okay? And again, I won't test you on this because I know it's fuzzy, but this is your G protein coupled receptor. There's a number of them that will utilize this signaling pathway in your arteries or veins, okay? Here's phospholipase C, right? And here is your L-type calcium channels over here. Guess what the target is for your calcium channel blockers? L-type calcium channel, right? These ones right here. This is where your drugs are going to work that we're going to talk about, okay? They essentially prevent calcium from moving into muscle cells, either allowing those muscle cells or tissues to relax or to reduce their force of contraction. Okay? That's what calcium channel blockers do. They limit the amount of calcium that muscle cells have access to, and that prevents those muscle cells and tissues from contracting forcefully or staying constricted. It allows them to relax, okay? It's like giving your vascular smooth muscle a Xanax, right? And now you're relaxed, okay? All right, allows them to dilate and relax. And what part of the MAP equation do you think that would change? Cardiac output or systemic vascular resistance? SVR, right? It's going to change SVR, all right, primarily, all right? We're going to talk about that in a minute. So again, all you need to know is this is the target for your calcium channel blockers, okay? That's in smooth muscle. Now in cardiac muscle, okay, in the heart, you also have calcium channels, okay? They are activated by different receptors and a different signaling pathway, the adenylyl cyclase pathway, okay? This calcium channel right here is a target for some of your calcium channel blockers, okay? Not all of them, but a very specific group of them, okay? And if we block this calcium channel here in heart muscle tissue, it's going to have two effects that are super important, okay? It's going to lower heart rate and lower stroke volume. How fast the heart beats, how forcefully it beats can be reduced by using certain types of calcium channel blockers. All right? Yes, sir.
Is the stroke volume reduced because of the contractility?
The stroke volume is reduced because of a reduction in the contractility, the forcefulness by which the heart contracts, right? So if you reduce heart rate and stroke volume, what part of the MAP equation is going to go down? This is the audience participation part, cardiac output, right? You got to know that. Okay? Some calcium channel blockers, we're going to talk about this, only reduce systemic vascular resistance. The other group of calcium channel blockers reduce systemic vascular resistance, but also reduce cardiac output. And you gotta know that that's where the differences come in. They all block the same calcium channel, but they do it differently, and that leads to some of the differences in their effect, okay? Okay. So let's talk about our first group of calcium channels, calcium channel blockers, okay? These are our dihydropyridine calcium channel blockers, okay? This is and you'll hear that used, that term, dihydropyridine, in the clinic, okay? Your doctors and nurses and stuff like that will refer to dihydropyridine calcium channel blockers and the other group, which is the non-dihydropyridines, okay? You'll see it as DHP or NDHP, okay? Now, your dihydropyridine calcium channel blockers, easy way to determine whether it's a dihydropyridine calcium channel blocker or not by looking at the name, okay? If it's got a dipene at the end of it, nifedipine, amlodipine is radipine, right? Okay? It's one of these. If it doesn't, it's one of the other two in the other group. Okay? You guys have all heard of verapamil and diltiazem?
Okay.
They're the ones in the other group. Everything else is a dihydropyridine. And you can tell because it's got that dipene. Okay, you got it? All right. Now, let's take a look at the pharmacophoric structure. Okay? You've essentially got, okay, two ring structures, aromatic and a nitrogen-containing ring structure here connected. Okay? Down here, this ring right here is referred to as the 1,4, wait for it, dihydropyridine ring. This is a pyridine ring here, this is an aromatic ring. So the name dihydropyridine comes from the chemical structure. One hydrogen here, one hydrogen here, dihydro, meaning two, pyridine ring. Okay, everybody got that?
Yeah.
Now, you can see that there's a lot of variety that we can get here with this pharmacophoric structure, a lot of places for substitution, okay? You can see here, all right, the ring structure, the pyridine ring here is numbered 1, 2, 3, 4, 5, 6. So, okay, we have got substitutions here, 3 different substitutions. Our first substitution here is at position 6, okay? Our second substitution here is at position 5. And our third substitution point over here is a carbon 3, okay? So again, depending on what functional groups we have on there, will determine pharmacokinetics, dosing, activity, those sorts of things, okay? Everybody got that? All right, efficacy, potency, right? All right, so here are your structure-activity relationships. I've got them all listed out here. You don't have to write them down, okay? So let's take a look at each one of them and go back to our pharmacophoric structure. So the first SAO, we have a substituted phenyl ring at the C4 position, optimizes activity. All right, so again, if you want you want a calcium channel blocker that's optimally active, you gotta have this aromatic ring here connected to the carbonate at position 4. I'm gonna give you a little hint here. All of your dihydropyridine calcium channel blockers have that. It's there for all, okay? Let's take a look real quick. Here's some examples, okay? Nifedipine, carbon 4, do we have an aromatic ring there? Absolutely. Amlodipine, carbon 4, do we have a ring there? Absolutely. Nicardipine, here's carbon 4, do we have a ring attached to it? We certainly do, right? And is radipine. Okay, we got it, right? That's to optimize pharmacological activity. We're good to go there? Everybody has it. It's in all of them, so don't worry about it. You don't have to worry about that, okay? Where things get a little bit interesting, okay, is if you have an ortho, here's that organic chemistry stuff, right? Or meta substitution, on that aromatic ring. If you do, that further increases activity, okay? And you're gonna see that most of them do. Okay, let's go back, okay? Here's your aromatic ring, okay? This is ortho here, right? This is meta here. And what's this one up here? Para, right? You remember your organic chemistry a little bit. What substitution do we have here? Ortho, right? O-N-P, ortho, meta, and para, right? O-N-P. So this is ortho. What about over here? Ortho. What about here? Meta, right? So they all have that for the increased activity. And isradipine has both, right? Sort of. It's connected by that ring, right? So it's got a substitution of that ortho and the metacarbon there, okay? Got it? So they all have that. Again, it's just to increase the activity of the drug, all right? Now, what's necessary for activity, they all have to have that 1,4-dihydropyridine ring that I showed you here. They've all got to have this here, with a hydrogen here and a hydrogen here. And they all do, because if they didn't, they wouldn't have any activity at all. And you wouldn't have it, okay? Now, we tried this out when we were experimenting with modifying the chemical structure of some of our dihydropyridine calcium channel blockers. And what we found was, if you put anything on that nitrogen in that 1,4-dihydropyridine ring, right down here, or if you reduce these double bonds in the ring, okay, that greatly reduces or eliminates activity. So we don't want to mess with that. You'll see here, okay? Do any of these drugs here have a substitution on this nitrogen besides hydrogen?
No.
Nope, 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 no. Do they all have the double bonds in the dihydropyridine ring? So they're good to go, right? We don't want to mess with that. You won't see that because, you know, the substitution or the elimination of the double bonds, because those drugs just don't work, so we don't make them, okay? Ester groups at C3 and C5 optimize activity, okay? All right? So again, if we go here, if we have an ester group here or here at position 3 or position 5, we can make sure we optimize that activity even further, all right? And so what you're gonna see here, ester groups here, see it in nifedipine, and here, does amlodipine have them?
Yep.
Yep. How about nicardipine? Yep. How about isradipine?
Yep.
Yeah, they're all slightly different, right? But they all have it. Okay? If I would give you a picture of a pretend calcium channel blocker, okay, that has no double bonds here, or a substitution of that nitrogen, and asked you, what kind of activity does this drug have? Could you tell me that it has no activity or little activity, right? Or if I gave you nifedipine, and I would tell you what it was, and I gave you a brand new calcium channel blocker that doesn't have these ester group substitutions, could you tell me which one has greater activity? Right? It would be the one with the ester groups, not the one that doesn't, right? All right? So again, that's a potential question I could give you. So as long as you can identify where those major points are, okay, and I give you a pretend calcium channel blocker that's a little bit different than this, maybe missing some of those things, could you tell me which one is more active than the other? Okay, I think you could. It's not hard as long as you know this. All right. All right. I think what we're going to do now, because I can tell we're all failing fast. It's humid in here. It's a little, yeah. Does it feel a little sticky to you? Okay. Why don't you guys go take like a 6 or 7 minute break, get some caffeine, use the restroom, take a walk out, whatever you need to do. Okay. Then we'll come back. We'll talk about the mechanism of action, and I'm here to answer any of your questions. Okay. Let me ask you this question. Let's take a look at it. I told you This week, we got calcium channel blocker. Would it be lower or higher? Yeah. This one and this one. Let's say I eliminated that nitrogen. Okay.
That's good enough. That's good enough.
These two extra.
Oh, that's good.
Yeah. Decrease it or increase it?
I just, okay. I saw.
Let's say I gave you this identical number. And you're getting What is the same? Okay, reduce, you already have it. Reduce by one.
If he does.
Very little is no activity. So that's it.
Yeah, cause like wasn't the fuck out, right?
What about actually?
I don't even feel like I was.
Would it increase activity or
I don't
decrease?
feel like.
It would almost like, you don't want to have it. How are you doing? Everything good? Yeah, it's pretty amazing. So you're Did I send you the call for the work on? Did I forget to send you hanging in there? You should have, right? Especially when you're young, right? Because your body has a lot of resilience right now.
I mean, I guess there's still.
Yeah, no, it's nice to know. That is. I know, this is if I was sitting out here with you guys, I would be totally silly. Totally silly. I could never stay away from time.
It's very far.
I know, and you guys are real troopers. I really need it. I know. I
like the class.
It was good to do. I like it too, but I understand that's a terrible time to have.
No.
Terrible time. All right, I'll let you get it. Good over here?
That's why I said. Oh. That's what I mean. Because you're. What about
And then Tuesday and Thursday. And then there's a lot of Friday.
Hey, I saw that. Now hold on. That was it. Okay, well, let's switch to
Okay, great. I'm so busy. I've never thought
Like on Friday.
Oh, you're right.
With ghosts, you know, I thought.
Go away.
Like, perfect, like stuck here.
Alright, good, good. I'm glad you're here. You're welcome. You're welcome. Ernesto, you got a question?
Yeah.
I can see the look on your face.
Oh no, I was just doing it's like, it's sleep deprivation and especially caffeine and because this is what we got some saliva from the sugar and we are trying to measure the cortisol level like caffeine just
I didn't I had an idea for a party.
okay
That was really quick. I mean,
okay yeah wait, I was gonna get to the hospital so we are basically using the RAS system where like because the RAS system is for like low blood pressure.
Yeah, it's
in a
for
way.
blood pressure.
So we're basically hacking our body to use it for lowering blood pressure.
Yeah, we're using, by using the drugs, we're
Yeah,
hacking that
yeah,
system, we're interfering with that system. That's exactly right. 2-minute warning, 2-minute warning. 2-minute warning. Two-minute warning. 2-minute warning. Sorry.
Dr. Yeah. So in like for the calcium channel blockers, do they like literally block the channel so calcium doesn't go in, or it does? Is it like in a special site?
Yeah, so the dihydro, and that's a good question, yeah. So that's the, we're not gonna get that advanced, but the dihydropyridines and the non-dihydropyridines bind and block calcium channels. Dihydropyridines non-dihydropyridines bind the calcium channel and hold it in its inactive refractory state. That's why it has cardiac effects that it has. Okay, but I don't think we're gonna get into that, but that's exactly why. They have the same target, they block the same protein, but they just do it differently. And that's what gives them the different effects that they have.
Okay, and
It's called use-dependent block with verapamil ties.
that's very interesting.
Okay, all right, let's get started again, all right? So thanks for coming back. Hopefully everybody had a good break. We're gonna continue to plumb the depths of the mystery of calcium channel blockers here, okay? Again, just as a recap from the beginning, okay? Calcium channel blockers are a first-line agent to treat hypertension, okay? There are two chemical classes, okay, of calcium channel blockers. We have the dihydropyridines and the non-dihydropyridines. We spent the first part of this lecture talking about the dihydropyridines, okay? How do you know whether a calcium channel blocker is a dihydropyridine or not? Look at the name. If it's got dipene at the end, okay, all right, it's a dihydropyridine calcium channel blocker. isradipine, nifedipine, cardipine, amlodipine. You get the gist, right? Okay? Now, all of our, and the other group are the non-dihydropyridines, which we're going to talk about now, okay, which include just verapamil and diltiazem, which you've heard of, okay? Now, the dihydropyridines have got a couple of different structure-activity relationships. We know what in their chemical structure optimizes their activity, right? You got to have a 1,4-dihydropyridine ring structure, okay? You've got to have a C4 substituent, that aromatic ring at the top of the molecule. If it's ortho or meta-substituted, it even further enhances activity. And if you've got ester groups at C3 and C5, that makes it even better. And if you look at all of the commercially available calcium channel blockers and dihydropyridine calcium channel blockers, they all have those features, okay? Now, let's take a look at how these drugs work. We're done with the med chem now, okay? At a cellular level, the cellular target for all of these drugs is the L-type calcium channel, okay? There are different types of calcium channels, okay? We're not going to learn about the other ones. There's the L-type. That L is a letter that tells us something about its size of the protein and how long it can stay open when it's activated. So L stands for large and long-lasting. That's what the L stands for, okay? There's a T-type calcium channel, which is tiny and transient, okay? So there's a couple of different types of L-type calcium channel. There's a couple of types of calcium channel blockers. We're only focused here on the L-type, okay? So that's your target right over there. There's just a cartoon picture of the IP3 pathway. Right over there on the left is your calcium channel, okay? That's what these drugs block. And by limiting calcium entry into smooth muscle cells, they cause those smooth muscle cells to relax, okay? And when they relax, resistance to blood flow does it go up or does it go down? It goes down, right? What does that do to blood pressure? SVR goes down. It reduces it, right? Very good. Okay. Now, and that's exactly what this is. We're going back to the MAP equation. Okay? I'm going to pause here for just 1 second to give you a pro study tip here with this. Okay? You are going to have questions about the MAP equation, right? I want you to know what the two factors are that contribute to blood pressure and how they're regulated in the body. The best way to learn this is not to listen to my PowerPoint presentation over and over again. It's bad enough to listen to it once, okay? You don't need to do it twice. But what you should do is pull out a blank sheet of paper or go to a whiteboard, right? And just write out the MAP equation. MAP equals cardiac output times total peripheral resistance. Then fill in as many details as you can. Cardiac output is a function of what two factors? Heart rate and stroke volume. What are three things that contribute to total peripheral resistance? SVR, elasticity, and viscosity, right? Now let's go down to stroke volume. What are things that determine what stroke volume is, right? Preload, right? Or sympathetic nervous system activity, contractility, right? What determines what preload is? Venous return, right? Or blood volume. You see where we're going with this? You know, again, it's only day 2. So if you're not comfortable with that, don't panic, okay? I've been doing this for almost 30 years, and very few people are comfortable with it in day 2, okay? It's okay. It might take a couple of days, but stick with it, all right? Because if you understand that, it makes it a lot easier to understand this. You could always memorize this if you want to, and it'll probably get you through the exam. Understanding is so much more fun, okay? At least fun for me. So, back to our dihydropyridine calcium channel blockers. The hemodynamic effects, the effects on the MAP equation, very simple. All these drugs do is reduce systemic vascular resistance. That reduces total peripheral resistance, and that reduces blood pressure, okay? These drugs are really good at relaxing arteries, okay? Relaxing arteries. They're very good at that. Okay, and because of that, you have some side effects associated with that I'm going to talk about in a minute, right? Notice, is there any effects on cardiac output or the heart over here? None. All right? But when we talk about the other group, the non-dihydropyridines, diltiazem and verapamil, they are going to have additional effects on the heart that we're going to talk about. Okay? Yes, sir.
Is like constipation one of the side effects because of like
Constipation is a side effect of your calcium channel blocker. Yeah, why do you think that's the case? What does smooth muscle in the GI tract need to contract and keep that stuff moving through your small and large intestines? Calcium, right? Do you think those calcium channel blockers might affect that smooth muscle too? Absolutely, and slow gastric motility, things get kind of backed up, right? Okay? Yeah, that's a side effect. Okay, definitely. Everybody got that? All right. All right, now we're shifting gears. We're moving into our other group. These are our non-dihydropyridines. Okay, creative name for this group. All right. There are two types. Okay. There are your benzothiazepine calcium channel blockers. That is diltiazem. Okay. Because of the benzothiazepine ring right here. You see it? This big ring structure in the middle of diltiazem? That's your benzothiazepine ring structure. That's where it gets its name. This is the only drug in this category. Okay? Frankly, folks, I'm going to tell you right now, you will never ever hear the word benzothiazepine calcium channel blocker in a clinical environment, ever. So I don't really care that you know it. What I do care is that you know that diltiazem is a non-dihydropyridine, because you will hear that, okay? Write that down. It's a non-dihydropyridine, or NDHP. You'll see that in medical notes all the time, too. DHP or NDHP, okay? Everybody got that? The next two things I'm going to tell you, pay attention, are for your information only, meaning I'm not going to test you on them. I just want to mention it because it's interesting, okay? Diltiazem, all right, has chiral centers, which means when it's produced as a racemic mixture. You guys, we talked all about racemic mixtures. Here's an example here, okay, that both isomers actually have activity, but one isomer is way more active than the other, okay? The plus isomer is about 10 times as potent as the negative isomer, okay? They both have levels of potency and activity, but the positive isomer is way more potent than the negative isomer, okay? They're still manufactured as a racemic mixture, okay? And again, these drugs have a high lipid water partition coefficient, meaning that they cross biological membranes relatively easy. They're pretty lipid soluble. Okay? And that's really important if we were to have an advanced discussion about how these drugs work, and we're not going to, but diltiazem actually has to get inside of the cell and binds to the inner part of a calcium channel, okay, to inhibit it. So it's got to be able to cross the cell membrane and get where it needs to go. Your dihydropyridines don't need to do that. Okay, they're lipid soluble, but again, it's important for diltiazem and verapamil to be lipid soluble so they can get inside the cell and bind to the calcium channel. Okay. All right. Here's the difference. You got to star this slide because it's important. Okay. This drug, diltiazem, will inhibit L-type calcium channels in vascular smooth muscle, just like your dihydropyridines will, okay? So that's an identical feature between both big classes of calcium channel blockers, okay? So this is one major effect, but it also blocks L-type calcium channels in the SA and AV node and in the myocardium, which is a fancy name for cardiac muscle. I gave it to you right there, okay? Now, let me ask you this question. What effect do you think that diltiazem will have on heart function if it blocks the SA and AD nodes? What do you guys think? SA node does what? Fires action potential spontaneously, right? And it sets what? How fast the heart beats. So and it uses calcium to do that. So if we block at the SA node with a calcium channel blocker, what do you think is going to happen to heart rate?
Heart rate will come down.
Heart rate is going to come down. It's going to lower heart rate. Okay? So this first one will lead to a lowering of heart rate. Calcium is, access to calcium is really important for the SA node, right? Which is the structure that fires spontaneous action potentials and sets the rate at which the heart beats. So if you limit its access to calcium, right? The rate at which it fires action potentials and the rate at which the heart beats will go down. Okay? So all you have to do is right next to this, lower HR. It's not human resources, it's heart rate. Okay? All right? Now, myocardium. What if we limit access to calcium? What if we limit the access to calcium in cardiac muscle? What's it going to do?
Muscle contraction.
It's going to limit muscle contraction, right? It's going to lower muscle contraction. Okay? Thanks for that, because I forgot to mention that. All right? There are technical terms for this that I want you to know. Okay? You guys ready? Everybody got their pens ready or their tablets? Because it's not on here. Anything that lowers heart rate is a negative chronotrope, or negative chronotropic, negative chronotrope, okay? Chronotrope, spelled like it sounds, okay? Negative chronotrope. Chrono means time. Yeah, that's how I always remember it. Chronotrope. So any drug that lowers heart rate, like diltiazem or beta blockers, negative chronotropes. Okay, you'll hear that term. That's a technical, scientific, and clinical term. Okay. Drugs that reduce cardiac contractility or the force generated when cardiac muscle contracts are negative inotropes. I'm sure Dr. Joshi talked to you about this in biomed. Might be a little bit of time since you learned it. Okay? Negative inotropes. Chronotrope refers to heart rate. Inotrope refers to force of contraction. Okay? When you're done writing, look up at it. And I'll repeat it if you need me to. Now, I don't want you to blurt the answer out. I'm going to ask you a question and see if you get it right. Don't blurt the answer out, but think about it for a second. Using the terms chronotrope, which refers to heart rate, and inotrope, which refers to force of contraction, describe the effects. Now, I want you to do this in your head or write it down of epinephrine. Epinephrine. All right, don't sound it out, write it down. Okay? Using the terms chronotrope and inotrope. Think about what epinephrine does to the heart. Okay? And using inotrope and chronotrope, tell me, describe what it does. Okay? How would you describe it using the term chronotrope? Anybody want to tell me? What do they think?
Positive.
Positive chronotrope, right? Because it increases heart rate.
Yes.
Everybody got it, right? How about inotrope? It's a positive inotrope too, right? It increases force of contraction, right? When your fight or flight response kicks off because that grizzly bear is coming in here. Okay? Right? Your heart rate's going up. Your force of contraction is going up. You know why? Because your adrenal gland just dumped out all those catecholamines into the bloodstream, epinephrine and norepinephrine. Your sympathetic nerves are firing, right? Okay? Epinephrine, norepinephrine, positive chronotropes and inotropes. It's just a way of using the term. I just want you to understand what chronotrope is and inotrope, all right? Okay? Yes, sir.
So it's the same dynamic with the caffeine?
Yeah, caffeine, you could probably say it's in some people. Now, in me, because I'm totally like resistant to the effects of caffeine after many, many decades of drinking it, but if it makes your heart race, it's positive chronotrope. Okay? Yeah, some people are more sensitive to it than others, yeah. But yeah, I think you could classify caffeine as a positive chronotrope. Sure, absolutely. Okay? Good example. There are a lot of examples of that. Okay? All right. Everybody got this. So let's look at the hemodynamics now. Super important. I want you to think about what the dihydropyridines do. Nifedipine, nicardipine, isradipine, amlodipine, right? All they do to the hemodynamics is what? They reduce what? The first group of drugs we talked about. TPR and SVR, right? They only relax your arteries. That's all they do. Notice what diltiazem does. Yeah, it does a lot here, doesn't it? Okay? Let's start over here on the right. This is where the similarity is. Do they reduce SVR? Does diltiazem? Yeah, absolutely it does. Okay? And that will reduce TPR. Right? So that's a similarity, and the only similarity between your dihydropyridines and your non-dihydropyridines. Okay? Everybody got that? Compare and contrast, look for similarities when you're remembering these things. Now, this is where things get different. Stroke volume. Diltiazem reduces stroke volume, and it reduces heart rate. Okay? And that reduces cardiac output. So with diltiazem, you get both a reduction in TPR and in cardiac output, right? Pretty good, right? Okay? How does it reduce stroke volume? Okay? By reducing force of contraction, inotropy, right? And by reducing afterload. Both of those will reduce stroke volume. And that in turn, along with a reduction in heart rate, will give you a reduction in cardiac output. Right? Everybody got that? So again, diltiazem and verapamil does a very similar thing, but to a little bit different degree. Okay? Your non-dihydropyridines are a little bit more complicated in terms of the mechanism of action. Okay? They have the additional effect of lowering cardiac output by lowering heart rate and stroke volume. Your dihydropyridines are pretty simple. They're vasodilating agents. They dilate arteries and reduce TPR, right? So you have to know similarities and differences between the two categories. Okay, everybody got that? All right. Questions?
No, it's not a question, more like a statement.
Yeah, statement. Okay, go ahead.
Dihydropyridines are more selective in a way?
They are. So the way that the reason your dihydropyridine calcium channel blockers only relax arteries and don't have any cardiac effects has to do with the way that they bind the L-type calcium channel. Okay? Now, and I can get into that a little, you don't need to know this, and I'm not going to test you on this. But if you think about how the heart functions, it's constantly contracting, right? And the calcium channels in the heart are constantly opening and closing, okay? Your L-type calcium channel blockers like nifedipine, nicardipine, and isradipine kind of block the hole in the calcium channel that calcium goes through. It makes it really good at blocking smooth muscle, which only utilizes those calcium channels occasionally contracted out. Diltiazem does something called use-dependent block. It binds to the inside of the calcium channel and stabilizes it in its inactive or refractory state, which we didn't get into, okay? And so that's why it's so effective and sensitive your heart muscle is so sensitive to it because of the way it binds and blocks the calcium channel. You guys don't need to worry about that, okay? If you're interested in it and you'd like to learn more, I'm more than happy to talk about it with you individually, but I won't test you on it. But you do need to know this, okay? And there's a reason for why this happens, okay? You got enough to learn as it is already, okay? Everybody got that? But if you're curious, I'm more than happy to talk to you about it offline. Kingsley.
You mentioned about the L and T.
I'm sorry.
You did mention about the L and T calcium channels.
Yep.
When you were talking about the DHPs. Would
Yep.
that apply here as well?
So all of your drugs, all of these calcium channel blockers, no matter what they are, only block L-type calcium channels. Okay? I only mentioned the T-type just because it was just to show you that there are different types of calcium channels. But the L-type are your predominant targets for all of those. Okay? Everybody got it? We're good? All right. Everybody understand this here? Who's got questions? All right. The next non-dihydropyridine calcium channel blocker is a phenylalkylamine-based drug. You don't need to know that. But if you look at it, okay, here's the name if you're curious, right? This is why it's got that chemical name. Phenylalkylamine. See it? All right? There's only one drug in this class. It's verapamil. Don't go into the hospital and say, I'd like to talk to you about a phenylalkylamine calcium channel blocker, because they're going to look at you like you got two heads, okay? What you need to go in and say, well, there are two types of non-dihydropyridines. We've got diltiazem and verapamil, okay? And they both lower SDR, heart rate, stroke volume, they're good at lowering blood pressure. Your preceptor will be super duper impressed, okay? You've just told them more pharmacology than they remember, okay? Got it? Some of them. Some of them might know more, okay? Now, again, another example of a chiral molecule that is, when it's synthesized, it's produced as a racemic mixture, okay? Again, one isomer here is more active, a plus isomer, than the negative isomer. You don't need to remember that. You don't need to know it. You can cross it out, FYI. It's just there for completeness, okay? So again, in order to make this drug soluble in water, okay? And again, I wish Dr. Naeem were here because, some of these calcium, like for example, if you wanted to use, and we do use calcium channel blockers in emergency situations, I believe, right? Where you have a hypertensive emergency or crisis, right? In order for you to put it in an IV fluid, right? To administer via IV, it's got to be water soluble, right? The problem with a lot of these, as you can see from these calcium channel blockers, like the dipines, right? And verapamil or diltiazem, and even verapamil here, just based on the chemical structure, you predict are probably not very water soluble, right? Which means, again, if you wanted to administer one via IV, it'd be tricky. Verapamil you can conjugate with hydrochloric acid, and you can make a salt out of it that I believe you can use in an IV. Don't quote me on that, okay? Dr. Naeem will talk about that. All right, but again, that's something to consider when we talk about these drugs, okay? Site of action, again, same thing. L-type calcium channels, okay? Just like everything else we've talked about, that's the molecular cellular target, okay? Now, again, like diltiazem, vascular smooth muscle, okay? What do you think it's going to do to SVR? It's going to go down, right? SA node. It blocks calcium channels in the SA node. What do you think that's going to do to heart function? It's going to do what? Lower heart rate. What fancy term did I tell you to use for that? Negative chronotrope. Don't forget that, okay? Chrono means time and refers to the rate at which the heart beats, okay? It blocks L-type calcium channels in cardiac muscle. What do you think that's going to do to cardiac muscle function? Is it gonna reduce force of contraction, increase it, not change it? What's it gonna do? To reduce, what's the fancy word for that? Negative inotrope, right? And both of these together will reduce what hemodynamic factor in the MAP equation? Cardiac output, right? Heart rate is reduced, stroke volume is reduced, cardiac output's reduced. And what else is reduced? SVR, TPR, right? Here it is right here. If you can predict this based on your knowledge of it, like where it works, okay? It's a lot easier than memorizing it. If you know that these drugs relax blood vessels, automatically you know that they reduce SVR and TPR. Any drug that does that will reduce SVR and TPR, okay? Whether we're talking about ACE inhibitors, whether we're talking about ARBs, whether we're talking about calcium channel blockers, alpha blockers, hydrochlorothiazide, they all relax arteries. So they all reduce SVR. Any drug that lowers heart rate and or force of contraction of the heart will reduce cardiac output, okay? So if you understand this, you can make a good guess at least, right? And that's okay, all right? It's okay. If you're taking a test and you take a guess, an educated guess, based on your thought process and you get it right, good for you. Because guess what? That's the secret to being successful in the NAPLEX, is using whatever knowledge you have to puzzle out a question and get the right answer, okay? That's the secret. Because can you remember everything?
No.
No way, okay? All right. This table summarizes the effects. Who here loves tables? You guys, some students love it. You guys like tables? If you don't like tables, you don't even need to look at this. All the information that I've given you already, perfect, okay? This is repeating it in a different format, all right? But let me go through it so in case you look at it, you're not freaking out because you don't understand what these numbers mean, okay? All right, over here, we've got 3 types of calcium channel blockers. Nifedipine, what group does it fall in? Dihydropyridine or non-dihydropyridine? Dihydropyridine. Diltiazem, dihydropyridine or non-dihydropyridine? Verapamil, dihydropyridine or non-dihydropyridine? All right, good. You learned something. I'm glad. Good. Right, now, here is all of your cardiac effects, okay? Systemic vasodilation. Again, if you don't like that term, which is not great, I mean, it's accurate, put in SVR. Reduction in SVR, or reduction in afterload, or reduction in TPR, okay? You could substitute that in there, same thing, okay? The bigger the number, the bigger the effect. 5 is your greatest effect, 0 means no effect. Okay, if we look down through here, 5, 3, and 4. Do all of these drugs reduce systemic vascular resistance? Yes. They do, okay? Are there some slight differences between them?
Yes.
Yes. Do you need to know that? No, you don't, okay? All right? You don't need, I won't test you on that. These are just relative numbers here, okay? Look at nifedipine. Does nifedipine decrease cardiac contractility or ionotropy? Nope, it's got a 1, right? Maybe a little bit, but it's really not there, right? How about depression of the SA node, which would lead to a reduction in chronotropy or heart rate? No, not there. Depression of the AV node, which is part of the electrical conduction system of the heart, nothing there. So again, nifedipine, only SVR. Look at diltiazem and verapamil. Go across the board. Big numbers there? Yeah, pretty big numbers there, okay? They all reduce SVR, but they also reduce stroke volume, heart rate, and overall cardiac output. Everybody got it? Fantastic, okay? If you like pictures versus tables, here's the picture that summarizes everything. It says the same thing that the table tells you. It also tells you everything I've already told you. Okay? So if you're panicked the night before the exam and you don't know anything about calcium channel blockers, which would not be a good thing, I would suggest going right to this diagram here, okay? This might save you. Okay? Non-dihydropyridines? Give me the two examples. Rapamycin? Very good. And how do we know whether a drug is a dihydropyridine? Because it ends in what? Very good. Okay, good. All right. You see it there? You guys good? All right. Fantastic. What questions do you have? We're not done yet either. Okay. We got 20. Jess, how long do we have? Tell me, Jess. We have 10 minutes? Yeah. We have 10 minutes. Is it 3:20 class is over? All right. I think we're going to be done for the day. If you have any questions about what I just covered, I'll stick around for a few minutes because we're all ending a little bit early. Don't get used to this because it doesn't really happen here. And don't tell Dr. Naeem, otherwise I'm being recorded, I guess, okay? Tell her because I might be in trouble, all right? Great job today. Stay with it. Don't get frustrated, okay? It takes a little bit of time. Don't wait to come and see me and ask questions. I will tell you, I am out of the office all day on Thursday. I'm not here. Okay, your exam is when?
27.
Which is when? Next what? Next Wednesday, right? Okay? So again, I'm gonna have a review session at some point before then. All right? I'll let you know whenever I figure that out. Okay? Come and see me if you have questions. Yeah, don't worry. I wouldn't even worry about it. I would focus on it. Yes, sir.
Right.
Hey guys.
Those are senior Yes, sir.
Oh, they don't know how to access it themselves.
Ah,
Okay.
it was there.
Okay.
So, I think we could ask.
Thursdays aren't cool.
It's done, so it's already there.
You just bring it, I don't know.
Do you want me to check it for you? Add me as a member.
I need to. Okay.
If I can have access right now, that should be good. Cause it's admin, contact my name.
Cases in the office.
Jason.
There is, here's the thing,
Yes.
and I didn't get into this.
Cause everyone who you added there already can have access. Cause you have access. But I don't
Yeah.
Calcium channel blockers have a slightly different effect on that hemodynamic across the capillary. It doesn't, is not necessarily good for that. Whereas ACEs and ARBs
What was the NCP?
are much better.
Oh, right here.
They dilate both the arterial and the vein, which
They
increases
receive an
blood flow
invitation,
across.
so they
Where
should
the
go
calcium channel
to.
blockers
Teams.
I have access. Yeah, if they open up Teams, they should be. It should be right there. It should say NCPA.
2024.
Yeah, well, we're talking about, we're not, we're talking about.
Yeah, it might be that they're just not on Teams because they've never done it before.
Yeah.
So they need to open Teams, then.
Oh, you're talking about that.
For it to be able, they're going to
It's-
take the invitation.
It should, as soon as they open up Teams, it should just pop up.
Yeah, like for example, like this one, so you have NCPA, right?
Just go back to all Teams.
Yeah, all teams.
Like when they open it, it should look like that.
Yeah.
Alright.
So let,
That's because of the
let them know
selective
that
advantage.
they need to use their laptop in order to fully have access to it, but like, I know.
I use my iPad.
Yeah. Yeah, it
Yeah,
should be
I can use my iPad and my phone to have access to Teams, so.
Okay.
Yes.
Oops.
Okay, let's do it.
Let's go.